Assalamu alaikum and good evening, IMANA community. I hope everyone is doing well. We are back with another monthly IMANA education webinar. And this evening, we have Dr. Lodhi here, and she is going to be presenting us with a very well-requested topic, which is on a women's health issue known as menopause. And we're going to go through the basics. This webinar is a Menopause 101 session. For those who are listening, especially those on the recorded session, we have our physicians, our residents, our medical students, other medical healthcare professionals. I'm sure that this is a topic that many of you have come across, and especially within your patient setting. And so this is something which it's important for us to go through those basics and an opportunity for you to discuss with a professional any questions that you may have. So let me go ahead and introduce our speaker for this evening. We have Dr. Lodhi. She graduated from the University of Michigan, Dearborn, magna cum laude with honors with a Bachelor of Science in Biochemistry. She then went on and attended Michigan State University College of Osteopathic Medicine and completed a residency in obstetrics and gynecology at St. Joseph Mercy in Pontiac, Michigan. She relocated to New York after marriage, and she now provides gynecologic and obstetric care for patients at private practices, hospitals, in a community clinic that serves underprivileged women and adolescents. It is an incredible honor to have Dr. Lodhi here, especially given her very tight schedule. On behalf of the IMANA community, we thank you and appreciate you so much for taking time to educate us. And I'll go ahead and pass the mic on to you whenever you're ready. Jazakallah khair.
Assalamu alaikum. And thank you so much for having me on. I really appreciate the opportunity. And it's actually my honor to be here. Thank you for that introduction. I'm just going to tell you a little bit more about who I am and kind of a little bit about my certifications, and then I'll go ahead and get started with the webinar. So, as you know, I'm an OBGYN, and I am actually also a Menopause Society certified practitioner, as well as an ISHWSH fellow. ISHWSH stands for the International Society for the Study of Women's Sexual Health. So I'm a fellow of that. I am also a coach, a life coach. I received that from Rutgers University, and I obtained a certificate in sexual counseling and education from the University of Michigan in Ann Arbor on sexual counseling. So basically, the reason why I focus on menopause and perimenopause and sexual health is because we just didn't receive very much of that information in our training, at least in my training. I know I didn't, not very much in medical school, even in residency, I didn't get very much. And I am part of that generation of physicians where in 2002, the WHI study came out, and it was kind of like that shot heard around the world, where basically right after that trial came out and the study came out, everyone stopped giving hormones. Hormones were thought that it was bad, it was awful, it was going to cause breast cancer. We don't do it. Overnight, women were told to throw away their hormones. And, everything was just awful with hormones, and that was it. And so then, generations of women went through menopause, perimenopause without any treatment. Basically, if they begged their practitioner, they were given something, hormones, we know it was like the lowest dose for the least amount of time. And that was the dogma that was taught to all of us. And basically, we just didn't know how to manage it. So I thought, as I get older, as my patients get older, it's really important for me to learn. And so that's why I'm here today. Next slide. So I just told you a little bit about me, and I'm going to go on next slide. So this is kind of what we're going to go over today, basically understanding what happens during menopause. I'm not trying to insult anyone's intelligence. I know everyone here are healthcare providers. So, but I just want to go over the basics. It doesn't hurt just to go over them, and just common physical symptoms that you may hear your patients talk about, experience, kind of what happens. And also then, if we have time, we'll get into intimacy-related issues. I think this is very important, only because We just don't talk about it. Our patients don't talk about it. We feel uncomfortable. Our patients feel uncomfortable. And if they see that we are uncomfortable as physicians, then they won't approach the topic with us. And then they'll continue to suffer in silence, which happens in a lot of our communities. And so I think it's really important that even if you don't feel comfortable, that you find a practitioner that you can refer to that does feel comfortable talking about sexual health, and then, your patients can get their needs addressed. So let's dive into understanding the impacts of hormones during menopause, starting with what actually happens in the body and the common physical symptoms that you might notice and how these changes influence intimacy and relationships. So why should we even bother learning about menopause? Okay, so a lot of my slides are from the Menopause Society. So it used to be called the North American Menopause Society, and now they changed their name to menopaussociety.org. And, anyone can get some of their slide decks. They have a slide deck that talks about menopause and all these things. And so if you're interested, you can definitely look them up and also take a look at what they have to say. But basically, roughly 20% of the workforce is in menopause, right? The menopause transition. Women that experience menopausal symptoms were found to be 8 times more likely to report difficulty attending meetings. We know that a lot of women will forego promotions in their job because they just can't handle it, and also because they feel embarrassed that they may be suffering from brain fog and they don't feel like they can take on additional responsibilities due to this menopause transition, perimenopause. We also know that some of the symptoms that we always hear, are hot flashes, night sweats, mood swings, but there's more than that. And in fact, there's so many symptoms that women go through. We know that Oprah Winfrey talks about her menopause transition and says one of her first symptoms was heart palpitations. We know that the woman that wrote the article on women have been lied to about menopause in 2023, that was the most downloaded article in the New York Times. Her name is Susan Dominic. And she says her first symptom was brain fog. So, I think that it's not one size fits all, and it's really important to see what women are going through. So the severity of menopause symptoms correlates more with emotional exhaustion, less work engagement, negative self-perceptions, negative self-esteem, body image, all of that. So it's really important for us to understand what is happening during perimenopause, menopause, so that we can help assist our patients navigate this very important transition. We also know that women are now living about a third of their lives in this menopausal transition, right? So we can then appreciate why it's so important for us to know and figure out ways that we can help women live their best lives during this time. So the economic and lost human capital burden of menopause symptoms in the workplace. So if you take a look at this, so severe menopause symptoms are associated with higher rates of sick leave, productivity loss, less motivation, reduction in hours. The economic cost actually is really quite staggering. If you take a look at it, estimated U.S. Cost is 1.8 billion economic dollars lost per year. The cost increases to 26.6 billion annually. With addition of medical expenses, and 1 in 10 UK women aged 45 to 54 reportedly leave their jobs because of the menopause symptom burden. Next slide. This is a very important slide. This is a slide, I think that any menopause lecture that you end up going to will always have this slide. And basically, this is the straw plus 10 slide. And what it does, it provides clinical criteria for each stage of reproductive aging. And it's based on the menstrual cycle. It's important to note that these criteria don't apply in all cases of primary ovarian insufficiency. So if this is basically based on if somebody's having like regular menses, right? So here what we have is it's based on when the menses stop, and then they have, the 0, the +1, the -1, and it's in perimenopause, and it also goes to postmenopause. And the line indicator in the middle is where actually menopause happens. And it tells you of, what criteria to use, what blood levels, what are we looking at, ovarian reserve, AMH levels, all of that stuff. So it's important to know, though, that if somebody goes through primary ovarian insufficiency or has irregular menses or has a hysterectomy or endometrial ablation, then we really can't use this criteria because they're not having regular cycles. So for those women, we have to use blood work, and the blood work and hormone levels. So typically, as I'm sure you know, in perimenopause, a lot of women will come come in and they'll say, hey, can you test my hormone levels because I just want to know where I'm at. But in perimenopause, we know that what's happening is that estrogen is kind of like a roller coaster, right? It's going up and down, up and down. And that delta between the highs and the lows is what causes those symptoms, those vasomotor symptoms, the mood lability. And so when we draw hormones during perimenopause, we may not get a great indication of where the patient is at, right? The FSH level may still be normal because they're still ovulating, they're still getting their menses, the LH level, so it's not going to be helpful. But if a woman is not getting her menses at all, right? If she had this endometrial ablation, so you don't really know where she's at, if she's has irregular menses the whole time, or if she has her ovaries, but she doesn't have a uterus anymore, she may not know when she's going through it. Although when that ovarian function starts to decline, a lot of women do get those vasomotor symptoms. So they do have some idea as to when they may be starting that transition. But at that point, you would want to get some hormone levels. So you would get, if a woman is not getting her menses, so for example, you would get an FSH level and you'd want to see that FSH level be greater than 25. You'd want to get an estradiol level, which would be less than 20, and an AMH level, which checks ovarian reserve antimullerian hormone, and that would be 0, which confirms the post-reproductive status in a woman. So what exactly is menopause? We know that menopause is when you go a whole year, right? So 12 consecutive months without a period. The mean age for somebody to go through menopause is between 45 to 55. Here in the US, it's actually probably 51 or 52. We divide it into 3 stages. The 3 stages are perimenopause, menopause, and then postmenopause. And the duration depends on certain factors. And we're going to go over what those factors are. So some of the symptoms that women complain about, and in my office, one of the most common symptoms that I have, besides the hot flashes and night sweats, is weight gain. We see a lot of women complain about weight gain that they have, and that's because the distribution of the visceral fat changes. In our reproductive years, women tend to carry more fat in their hips and their thighs, and then as the estrogen declines, then we have insulin resistance that builds up, and we get more of that android shape that we notice, where the visceral fat starts to deposit more in the midline for women as opposed to their hips and thighs. We'll notice that a lot of women can't eat the same things that they used to, that they gain weight very quickly, the metabolism goes down. So all of those things are very distressing to a lot of women. We also notice, and I'm going to spend a little bit of time on this, the genital urinary syndrome of menopause, where we see a lot of changes in the genital, the sexual, and the urinary symptoms that women tend to experience. There's also cognitive changes. Women experience a lot of brain fog. There's sleep disturbances. There's mood changes. There's thyroid dysfunction, increased bone loss. We know we start to lose bone after the age of 30. And then, of course, after estrogen goes down, that bone loss accelerates. So women are at risk for osteoporosis. There's definitely the onset, can be the onset of immune and rheumatologic diseases. Again, here are some more signs and symptoms. We know that it's a whole body experience, and that's what's really important. On the left, we have these classic symptoms, which are the hallmark changes that most women recognize, such as hot flashes, night sweats, sleep disturbances, and they're driven by hormonal shifts that impact daily life. On the right, we have other symptoms that are less commonly discussed, but definitely as important. Those would be cognitive concerns. A lot of times women will say that, they're in mid-sentence and they forget what they're talking about. They can't remember. They'll be, having a lecture or giving a lecture or whatever, and they can't remember what exactly they were going to say next. So really a big problem. I had a friend actually that, was giving a very important talk, and in the middle of her talk, she couldn't remember and she got really upset and actually walked off the stage. So, it can be very distressing. There can be memory and focus issues, physical changes such as bone loss, dry eyes, even skin changes due to collagen. We know that, we start to see the changes in our skin, right? So we have estrogen receptors throughout our whole body, and everything is affected. So as that estrogen starts to decline, women will experience hair loss, the collagen will change, maybe we'll start to see more wrinkles, more dry skin, and it can feel definitely isolating if not addressed. It's also very important to know how Their emotional well-being is being affected, body image, changes in weight distribution, intimacy-related issues, all of those things. It's so, so important to make sure that you address. And I find that it's very difficult with our current um, insurance-based systems to actually have a discussion with women, right? Longer than like 10 minutes. I mean, it's hard to cover all of these things. So if a patient comes in for an annual exam or whatever, and they're experiencing these symptoms, you may want to have them schedule another visit to discuss all these things, because there's no way you can get everything done, do their full annual exam, and then also discuss these symptoms and then discuss why these things are happening. It's just a lot. So, I would just ask that you probably have them schedule another appointment. So there's some things that we can control and there's other things that we cannot. So here are some modifiable things, which are the body mass index, and of course I say modifiable in quotes because sometimes, it's very difficult for women to lose weight during this time, especially if their metabolism goes down. And that's why you notice that a lot of women during this perimenopause, menopause timeframe will decide to go on GLP-1s to help them lose weight because they're having such a hard time losing that weight. Their mood and stress, if they're able to manage. One of the things that the Menopause Society says to help with vasomotor symptoms is cognitive behavioral therapy, which I guess they say, works. For me, it's hard to understand how cognitive behavioral therapy would work. Experiencing hot flashes, night sweats, and they're getting up in the middle of the night. I mean, to me, that's more physiologic than just in the brain. So, but it is a modality that they offer for women that don't want to go on hormones. And also symptom sensitivity, like how sensitive women are to their own symptoms. Definitely non-modifiable risks is ethnicity, hormones, at what point that they go through menopause, that's not something they can control. Onset of the hot flashes, genetics, those are things that they cannot control. This is something that's very, very interesting to me, and I think it's something that's interesting to a lot of people. And basically, what it says is that perimenopause is a time. So we know that menopause is a time where we have no period for a whole year, and everything thereafter is called postmenopause. And basically, we're in postmenopause until we die. Perimenopause is a time before menopause, and that varies based on ethnicity. And that was found out through the SWAN study. So basically, the SWAN study was a study that was launched in 1994, and it is a multi-center study that was done. And basically, it followed women through midlife, and it followed their physical, their psychological, biological, and social changes that experienced in midlife. What they found is that different women, based on their ethnicity, will go through perimenopause for different lengths of time. And I'll tell you why that's important. If we're saying that the mean age for somebody to go through menopause is 51, 52, then it's really important to know, based on somebody's ethnicity, how many years they're going to go through this perimenopause before they actually get through menopause. The reason why that's important is because a lot of women get dismissed. A lot of practitioners will say, no, you're too young. I had a patient come to me in the clinic that is 44 years old. And she said she'd been begging for hormone therapy from somebody that would listen to her. And everybody kept telling her, you're too young, you're too young, but she's Hispanic. And we know, based on the SWAN study, that Hispanic women go through perimenopause for 8.9 years. We know that African-American women will go through perimenopause, can experience perimenopause for about 10 years. And Caucasian women, about 7 years, Asian women for about 5 years, okay? And what they also found out is that a factor that a lot of people don't take into consideration is that women in societies that have been exposed to structural and systemic racism experience perimenopause for a longer period of time. So they did this study where they looked at African Americans, right? So in the SWAN study, they were looking at all these different ethnicities. They found that African American could tend to experience perimenopause for 10 years. But when they looked at these same women in Africa and looked at their risk of developing hypertension and diabetes, they noted that they had the same risk as anyone else in their country. However, when they came over to the United States and started experiencing systemic racism and structural racism, then after being exposed to that generation after generation of this chronic stress, that actually changed, that's called epigenetics, and that changed their DNA, changed the telomeres on their DNA, which shortened it, which made them at risk for more diseases like hypertension, diabetes, and also put them at risk for having them go through perimenopause for a longer period of time. So we know that due to this, women will experience a longer perimenopausal period. So if If somebody's going to go through menopause at the age of 51, if they are African American, and if they're telling you they're going through symptoms at age 42, 43, believe them, because, we know that they'll experience it for a longer period of time. So try to help them out, listen to them. Women really appreciate being listened to and not being dismissed. And I think that that's why it's so important. This SWAN study, like I said, has followed women between the ages of 42 to 52 and followed them for about 25 years, observing and monitoring all their symptoms. Interesting because, they didn't really talk about specifically in the study about Southeast Asian women, but I thought that, giving this study, giving this lecture, I thought it was pretty important to also mention about Southeast Asians and what they know, and actually Asians. The Asians, they said, Japanese and Chinese women, 4.8 to 5.4 years. What's interesting, when I looked at more studies and more research that had been done, they said that a lot of times Asian women don't really talk about their problems. They don't talk about the symptoms that they're having. So maybe, because this study was following these women, perhaps they weren't disclosing all the symptoms that they were having. And that could be part of the reason. It said women may not complain of severe vasomotor symptoms, Chinese and Japanese. They may report a lower importance of sex and suffer from low libido, but never talk to anyone about it. They may suffer from forgetfulness, joint and muscle pains. So although it says that they experience it for a lesser period of time, perhaps they just, one, may not have been asked the correct questions, or two, perhaps the women didn't feel comfortable discussing those symptoms. Here, when we talk about South Asians, so women that, it says here, India, Pakistan, Bangladesh, the average age of menopause in Indian women living in India is 46.7 years. The mean age of menopause for Pakistani women, what they noted, was 47 years. So this is much lower than women in Western countries, which we know, we said around 51, 52 is the average age for somebody in the US to be experiencing menopause. These women are going through menopause much younger. The reason why this is important, and I'll tell you this, is that, when we go through menopause, and recently I took a trip to Pakistan. I'm Pakistani. And so last year I went to Pakistan and I spent about 2 weeks there. I went and I spoke with my cousins and people there, women, female gynecologists. And she was telling me that, they don't have, at least where she is in Lahore, that they didn't have estrogen, they don't have progesterone, they don't have the hormones. When I asked my cousin, who's a gynecologist, I asked her, what do you do for perimenopausal women and menopausal women? She said, nothing. We don't do anything. We don't offer them anything. They just kind of deal with it. And that for us is really unfortunate because this has implications for midlife. We know that as estrogen declines, we know that the number one killer of women is actually cardiac disease. And for Southeast Asians in general, we have a higher risk of cardiovascular disease, in fact, and an increased risk of diabetes. So when we go through, and we know that estrogen is actually protective, estrogen protects us. So women, they've done studies where they've shown that women that go through perimenopause, that perimenopausal transition and into menopause, all of a sudden they start to build insulin resistance. Remember, I mentioned that a little bit. So due to this increased risk of building insulin resistance, women can become diabetic. And we already know the Southeast Asians are at a higher risk of developing diabetes. So these women end up developing diabetes, heart disease, and there's an increased risk of cardiovascular disease, dementia, osteoporosis. Indian women complain more of vulvar and urogynecologic symptoms. There's a higher incidence of cardiovascular risk factors during menopause transition, such as metabolic syndrome, insulin resistance, diabetes, central obesity, hypertension. And so that's why it's so important. I mean, not only to discuss it with your general population of women going through perimenopause, menopause, but also for specific populations such as Southeast Asians, looking at what their risk profile is, looking at and understanding the benefits of hormones for these individuals and how that may or may not prevent their cardiovascular disease, diabetes. But we know definitely that without estrogen, their risk of diabetes goes up, their risk of cardiovascular disease. But in general, for all women, the risk of cardiovascular disease goes up. And I'm going to go over that and I'll show you a slide. And discussion about sexual health can be quite challenging. We know that a lot of times in our communities, we do not discuss sexual health at all. And so for a woman to come into your office and talk to you about her sexual problems, that's just not going to happen. So you're going to have to bring that up. You're going to have to talk to her about it and ask her, is she experiencing pain with sex, right? She may be too embarrassed to tell you that because of cultural stigma and taboo. And so it's going to be really important that you discuss these topics with her. And mental health, we know that that's not discussed at all. So that's going to be also very important. And I'm going to tell you what happens in perimenopause and menopause. So again, this is just another slide showing you similar information that I talked about the number of years that women will go through all these symptoms. And what stands out is that 10% of women experience vasomotor symptoms for up to 20 years. Can you imagine going 20 years without sleep, without being able to focus? I mean, it's just so horrible. It's like being post-call all the time. And for anyone that's post-call, I mean, you know how miserable that is. So it just does not sound like fun. So how do vasomotor symptoms happen, right? So here's the pathophysiology of vasomotor symptoms. So this explains the multifactorial pathophysiology of vasomotor symptoms, basically showing you these KND receptors and neurons in regulating the GnRH pulse generator and their activation due to declining estradiol levels during menopause. So this activation disrupts thermoregulation, leading to hot flashes, which can be stopped by blocking these neurokinin receptors to restore balance. And we know that this is how actually Veozah works. So you know that there's a non-hormonal medication that people feel a little bit more comfortable giving out to their patients that are suffering from vasomotor symptoms, and that's Veozah, and it just came out in 2023. The problem with Veozah is that it can cause liver problems, and you have to follow those liver enzymes like every 3 to 6 months. You have to get baseline labs. I mean, it's pretty significant. So it's up to you if you want to give those, or, you know, perhaps your patient has a contraindication to hormones and you just don't want to give it. You don't want to be, you know, you don't want to worry about that. So you give her this, but then you still have to follow those liver enzymes. So I don't know. Okay, next slide, please. So the hormonal shifts in menopause. So basically, you know, as we know, we take a look at what estrogen is responsible for, progesterone, and what testosterone is responsible for. By the way, I also want to, let you know that testosterone is also very important for women. And we go into a little bit of what that function is as well. But basically, this slide highlights the roles of key hormones in women's health. Estrogen, we know, supports reproductive organ health, vaginal elasticity, bone density. Progesterone aids in pregnancy and cognitive function. Testosterone helps with libido and muscle maintenance. We know also that for hypoactive sexual desire disorder in women, we will prescribe testosterone to help with that libido, even though we do not, testosterone is not FDA approved for women. According to the American College of OBGYNs, you can give testosterone to women for a hypoactive sexual desire disorder in the dose of 1/10 of the dose of what we would give to a man. So in midlife, this is what happens to our hormones. So as the estrogen goes down, as the progesterone goes down, as the testosterone goes down, and you can have some bloating, some breast tenderness. Of course, you get those hot flashes, the night sweats, the palpitations, the headache, insomnia, fatigue, bone loss, vaginal dryness, pain with sex, all of that. Low progesterone. Here you can see what that leads to. You have some sleep disturbances, you have mood changes, loss of bone density, migraines. Low testosterone is the decrease in muscle mass and the low libido that we know about. So this is a little slide, and it says like bone loss is normal for a woman your age. Okay, I love this slide, and I have to tell you why, because I think it is fantastic. If you look at this, if you look at the X and Y axis, you see what's happening. You see that as the estrogen is going down and as we increase in age, you see what's happening and the different medical conditions that result as a loss due to that loss of estrogen, right? So here you see short-term symptoms, you see long-term diseases, and you see right away, you see the hot flashes, you see the night sweats, and then you also see the mood and the sleep changes, the cognitive changes, right? These are some of these early short-term symptoms that you may see in the beginning of perimenopause. If you look at that, urogenital symptoms, right? They start in perimenopause as that estrogen starts to decline, and they continue forever unless we help women with those symptoms. And I'll tell you how we're going to help women with those symptoms. But for right now, if you just take a look at that graph, you'll see that it continues all the way until basically they die. You also see the dotted lines. See, you see the dotted lines for the cardiovascular disease, osteoporosis. So what that's telling you is that these chronic diseases are starting to begin in perimenopause. And then the longer the woman goes without estrogen, without hormones, her risk of that disease progresses. So here you see cardiovascular disease, you see osteoporosis, and you see cognitive decline and Alzheimer's. Now, we're not saying that estrogen is going to prevent Alzheimer's. No, not by any means. However, estrogen does help with cognitive function. And so that's what it's showing you here. And I think that this is honestly, if you don't remember anything at all from my talk, just remember this slide because I think it's super, super important. And it's really important to discuss it with your patients as to what is happening to their bodies as a result of estrogen deprivation. Before I get into the pathophysiology of gender urinary syndrome, I want to talk a little bit about the mood swings. So, navigating the ups and downs of emotional ability is really important to women. And what I find fascinating during this time is that even women that never had anxiety or depression all of a sudden can develop anxiety and depression in perimenopause and menopause. And so, what's causing this? So, now we know that estrogen levels fluctuate during our reproductive years, right? And a reproductive cycle, and especially during menopause. And because of these fluctuations, these estrogen fluctuations increase new and recurrent bouts of depression. In fact, women are 1.5 to 3 times more likely than men to suffer from major depressive disorder during this time. This is due to the fact that most estrogen receptors in our brain are located in the amygdala, hippocampus, and hypothalamus. And that's why you can get when our so there's a doctor, and I'm sure some of you probably follow. Her name is Dr. Lisa Mosconi. She is a researcher out of Weill Cornell, and she has research that she's written a book called The Menopause Brain, and she published this paper, and she talks about these estrogen receptors that are, basically lit up during perimenopause and up until the age of 65, basically seeking out estrogen in our brains. And this just highlights how important estrogen is that in our brain, just for our brain function. And we know that the hippocampus is also responsible for memory, learning, emotion, and it holds short-term memories and transfers them to long-term storage in our brains. It also helps with emotional processing, including anxiety. The amygdala helps process emotions. So it's also linked to emotions, to memories, learning, and our senses. The hypothalamus manages body temperature, hunger, thirst, mood, sex drive, blood pressure, and sleep. So we know there's so many functions that estrogen is responsible for in the different parts of our brain. And when we don't have that estrogen going to that part of the brain, that's why we have so much anxiety and depression. And it's interesting because women during this time, instead of the physicians putting like all the dots together and realizing that this woman may be experiencing perimenopause, what they end up doing is she ends up having like this polypharmacy. During midlife is when women are prescribed the most amount of antidepressants and anti-anxiety meds. And the reason is, now we know why that reason is. As that estrogen goes down, the receptors are lit up in our different parts of our brain and they're seeking out estrogen, but it's not getting that estrogen. So then they have all these symptoms that come along with this. Let's talk about the slide that we have right now in front of us. And that is the pathophysiology of the gender urinary syndrome of menopause. Now, I want to highlight how super important this slide is, okay? Because I want you to understand what happens when we don't give estrogen to women in their perimenopause and in menopause. Look at that slide. Look at the tissue on the left, okay? You see how nice and plump that tissue is. Then you look at the tissue on the right and you'll see that there's less cells over there, right? There's less blood flow. The rugae are gone and the elasticity is gone. And women will have a lot of vaginal dryness, vaginal irritation. Some women will experience overactive bladder. They'll experience recurrent UTIs. We know that a lot of women die in nursing homes from urinary sepsis due to undiagnosed UTI. So it is super important. And I didn't even mention sex in all of this, right? So women will also experience painful intercourse during this time. So it is super, super important that even if you decide, or your patient decides, right? We shouldn't be deciding for our patients, that our patients should be deciding whether or not they want to go on hormones. If they decide, you know what, I'm never going to go on hormones, that's fine. That's up to them. I would behoove you to just discuss with them the taking care of their vulvar health because of the reasons that I just mentioned. And they have decreased lubrication, all of these things, and recurrent infections. The pH changes, the pH goes up, it makes them more susceptible to bacterial infections, yeast infections. I mean, there's a whole host of things that happen as a result of this decline in estrogen. So it is super, super important that even if your patients decide, I don't want systemic hormones, you at least tell them about vaginal estrogen. Vaginal estrogen honestly could save their life. So it is super important. It helps to maintain a healthy microbiota. It helps to regulate the pH. I'll tell you a quick story. I had a patient come to me. She's actually perimenopausal. She told me that for the last 3 years, she's been struggling with recurrent bacterial vaginosis infections, and she keeps going, and they treat her for BV. Then she gets a yeast infection. Then they treat her for the yeast. Then she gets the BV. And she said the cycle's been continuing for 3 years. She's like a mess. She's like in my office. She's crying. She's upset. And she wants to know, she's like, I don't know if you can help me, whatever. I said, well, all I can do is try. I don't know. We'll just see. Anyways, so I take a look, whatever. And then I prescribe her vaginal estrogen. And honest to God, I mean, hopefully, inshallah, she continues to do okay, but she's not had an infection since. And why did that even occur to me is because I knew that the vaginal estrogen is going to help balance out that vaginal microbiota. And if I do that, if I can normalize that microbiome, then hopefully she won't have this continuous cycle of BV, then yeast, then BV, then yeast that she's been struggling with for the last 3 years. So that's what giving vaginal estrogen does. It helps to really balance out that pH, and it helps to maintain the rugae that we need for that elasticity of that vagina, and also prevent recurrent UTIs. So here are some of the symptoms that you have with the gender urinary syndrome of menopause. Really important for you to look at, know, and understand. Again, similar picture. I almost like this picture better because you can see the blood flow on the left-hand side of that picture. You can see the tissue. You can see the normal microbiome over there. And on the right side, you see that the pH goes up when we don't have that estrogen. The elasticity goes down. They start to have decreased lubrication, pain with the intercourse, all of that stuff. The sensitivity goes down. And here you have the decreased blood flow, the tissue changes, all of that stuff. So super, super important. The first line treatment of vaginal atrophy, we don't even call it vaginal atrophy anymore, right? We call it gender urinary syndrome of menopause, but that is vaginal estrogen. And that hypoestrogenic state results in those anatomical changes, the vaginal dryness, the pain with intercourse, the reduced lubrication, and all of these bothersome symptoms. Surviving menopause with hormonal therapy. Okay, so let's just take a really quick look. Oh my goodness, I don't think I have that much time, but okay, so let me just go really quickly. And I know that this could be a whole different lecture, but let's just talk about the WHI study really quick, okay? And what did that report tell us? So we know it was a randomized placebo-controlled trial. It was a trial that was supposed to last for 8 years, but then was discontinued after 5 years. Okay. And they said, oh my gosh, all these horrible things are happening with hormones. We can't use them anymore. Get rid of them, throw them in the garbage. And that's actually what ended up happening. So then here I go with what exactly was the problem with that study, right? So basically the authors failed to acknowledge their own reporting of their non-significant data. Also, what happened is that they had given hormones to women that were way into menopause already. So there is a timing hypothesis that the North American Menopause Society states, basically saying that the best time to give hormones, if you're going to give hormones or if you're going to offer hormones to your patients, the best time to do it is within 10 years of menopause or less than the age of 60. That's their timing hypothesis. Now, other authors, there was an article in the Lancet in October of last year that said that these authors said, no, we should be offering menopausal hormonal therapy to women even who are into their 60s, depending on, it has to be individualized, and you have to look at their risks and benefits and see whether or not it's going to benefit them. The idea of doing it within the 10 years of menopause goes back to that slide that I showed you. Remember that those chronic diseases start to develop way into menopause, like into 10 years. Now we already have these chronic diseases. The idea is to prevent those chronic diseases from happening by giving those hormones, but also, of course, to alleviate the vasomotor symptoms. And we know that estrogen is FDA approved to relieve vasomotor symptoms and to prevent osteoporosis. And so here we just really quickly, they misinterpreted their data. The WHI study had women that were already 12 to 15 years into menopause and were without their premenopausal levels of estrogen and progesterone. The findings. So, okay, the other thing with this is that the estrogen, even with estrogen alone, they did not find the risk that they said was associated with hormone therapy. They said it increased breast cancer risk. It actually does not. And we'll go into what exactly their recent claims are. So now there was another study that was done that was, they reevaluated the WHI results, and that came out, I believe, a few years ago, they looked at 18 years later, the WHI study and what the study showed. And what they noted was that among postmenopausal women in the WHI hormone therapy with conjugated equine estrogen. So what were the hormones that were used in the WHI study? They used conjugated equine estrogen. So women that without a uterus, they just used estrogen. Then they had another arm with conjugated equine estrogen and progesterone. And the progesterone that they used at that time was medroxyprogesterone acetate. And that was a synthetic progesterone. And we know that that was actually the arm of the study that caused the problems. It was not the estrogen alone by itself. And so when they looked at that same study again and the results, when they reevaluated them, what they noted was that with conjugated equine estrogen plus medroxyprogesterone acetate for a median of 5 years, or just estrogen by itself for a median of 7 years, was not associated with risk of all-cause cancer or cardiovascular disease or total cancer mortality during a cumulative follow-up of 18 years. Basically, 18 years after the study, they looked at women again, and they noted that the women that had taken these hormones, those hormones were not responsible for cancer or their death or all-cause mortality. In fact, here, if we go to the next slide, look at the WHI recent claims. Okay, so this is from an article that was published in 2023, and it was called "'Tis But a Scratch." It was written by Avram Blooming, who is a radiation oncologist in Southern California, and he's about 80 years old, but he's one of the big doctors, anyways, that talks about estrogen. He wrote a book called Estrogen Matters, and it's a really important book for anyone that wants to read it. It's really good. It talks about the whole studies. It goes through all the different studies. So obviously my lecture here was just simply like surface level. He goes into depth. And if you want to know all about the different studies that were done, whether estrogen is safe, it's not safe, I would ask you to read that book because it's a very good book and it goes through all that. Really quickly. So the recent claims of the WHI, so a lot of what the statements that they had made initially about the WHI study, they have debunked those. And now they're saying that HT hormone therapy is the most effective treatment for managing vasomotor symptoms, that estrogen alone decreased breast cancer risk by 23%, while reducing breast cancer death by 40%. And that estrogen alone was associated with a decreased risk of breast cancer, decreased risk of death from breast cancer, and decreased risk of death from all causes. And there's many benefits of hormone therapy when started within 10 years of the last menopause. What does not having access to hormone therapy, what does that increase for women? So there's an increased mortality, especially women that have had a hysterectomy and had their ovaries removed and were not given estrogen therapy, increased risk of heart disease mortality, hip fracture mortality, increased healthcare spending. We know that as women go into menopause, that they will have a 1 in 3 chance, and some people even quote 1 in 2 chance of having a fracture. Whether that's a hip fracture, femur fracture, any type of fracture, there is a 1 in 2 chance. If you follow, there's also another study that came out last year in July. Her name is Dr. Vonda Wright. I'm not sure if you follow her. If you don't, you should. She's an orthopedic surgeon. She writes a lot. She coined the term musculoskeletal syndrome of menopause and talks about all the things that happen during menopause to women in the musculoskeletal system. And it's very, very important to take a look at that, understand that, and see what you can do. And even, again, if you don't believe in hormone therapy, you don't want to offer it, whatever, you should definitely let your patients make that decision and let them decide, and also, but tell them what else they can do, right? So if they're not going to do hormones, then they should do definitely weight-bearing exercises and heavy weights. Lift heavy weights, increase your bone density, increase your muscle mass. We know that muscle is the key to longevity. And if we want to live long, strong, healthy lives, it's so important to lift heavy weights. So encourage your patients to lift heavy weights, increase their protein intake, because if you're going to build muscle, you need protein for muscle. So increase your protein intake, increase your weight-bearing exercises, also increase your fiber in your diet. All of those things are going to be super helpful to you. And when we build muscle, we're also increasing our metabolic rate, which when we increase our metabolic rate is going to help women lose weight. So also if they increase their fiber intake, they're going to help lose weight. So I know that weight is very distressing for a lot of women. And so that's why I'm just mentioning these things for those women that are not interested in hormones. So here are the key takeaways. So for estrogen, alone reduces the risk of breast cancer by 23% and reduces breast cancer risk by 40%. Medroxyprogesterone acetate, we don't even give that anymore. Honestly, we give micronized progesterone, which is more bioidentical. It's FDA approved. You can give micronized progesterone. We give estradiol, which is again bioidentical. So we don't even use the hormones that they had used in that WHI study. We use, safer hormones. We do transdermal. They were doing oral. Transdermal, we know doesn't go through that first pass effect of the liver and definitely does not increase your clotting risk, does not affect the liver, is cholesterol stable, it does not increase your cholesterol. So a lot of good things with transdermal. Let's see here. So there was no association between estrogen and progesterone and breast cancer was found to be statistically significant. The findings of the WHI did not apply to women starting hormone therapy in perimenopause and early menopause. Again, like I mentioned, with the WHI study had women that were already way into menopause, 12 to 15 years into menopause. And so we know that there is definitely more benefit to starting hormones earlier on in perimenopause and menopause as opposed to starting them way later on. But even that now people are starting to look into and find out, does this timing hypothesis, is it still relevant if the patient is healthy? So this is that timing of hormone initiation. This is the one that I was talking about. It emphasizes the timing hypothesis for hormone therapy, showing that initiating hormone therapy closer to menopause can reduce the cardiovascular risk and cognitive risk, while delayed initiation may be harmful, but even that is up for debate. Evidence from studies like the WHI highlight that hormone therapy within 10 years of menopause onset lowers coronary heart disease, reinforcing the importance of the timely intervention for optimal outcomes. So this is from the most recent guidelines from the North American Menopause Society, Endocrine Society, ACOG, and hormone therapy remains the most effective treatment for vasomotor symptoms. Women under the age of 60 within 10 years of menopause, and individualized therapy should be incorporated into the health and quality of life and just seeing what the patient wants. Okay. So indications for, again, same thing, indications for hormone therapy is, prevention of genitourinary syndrome, menopause, prevention of osteoporosis, vasomotor symptoms. Obviously, you don't want to use it if there's contraindications that are present for which may be an estrogen-dependent cancer, a DVT, PE, stroke, active liver disease. The decision to take or not to take hormones obviously should be, based on the patient's risk factors and what they decide they want to do. Even if, and again, like I mentioned before, even if the patient decides they never want to take hormones, really important to at least give them vaginal estrogen to help maintain their vulvar health. Again, FDA indications for hormone therapy use, and I just list them over there. These are from the Menopause Society, so you can take a look yourself. And if this is, if I'm running too fast through these, you can definitely take a look. Again, definitely if somebody goes to premature ovarian insufficiency less than the age of 40, you want to definitely give them hormones, at least up to the time of natural menopause, which is 51, 52. So make sure you at least give them hormones until then. If they decide not to take hormones after that, that's definitely up to them. So these are the different types of therapies, hormones that are available for treatment. You have systemic hormone therapy, local estrogen, you have SERMs. These are, if you don't want to do hormones, these are definitely something that you can give women for the hot flashes that they're having. SSRIs, Paxil, Veoza, gabapentin, clonidine, oxybutynin. Next slide. These are the benefits to estrogen hormone therapy. And this is something that I firmly believe in, but, I think that that's really important and something that is important for our patients. I'm going to just skip all the way to the very end because I go into a little bit about libido, and I think that we're running out of time. So, there are medications that are available for low libido. So libido is something that we don't talk enough about, but definitely happens during perimenopause, menopause. And as our hormones go down, as the estrogen and progesterone go down, testosterone also goes down. And so and we know that testosterone is responsible for not only muscle mass, but also libido. And so if that is bothersome and troublesome for your patient, then it's really important that you help her address that. There are 2 FDA approved medications for libido right now that we have. One is called Vyleesi, which is an auto injector, and the other one is called Addy. Addie was approved in 2015 and Vyleesi, I believe, in 2019. And of course, you can also give testosterone. It's not FDA approved, but it is recommended by all the different societies, the ISHWISH, by ACOG, by the Endocrine Society, to give to women that have low desire. So that's something that's definitely available to you. And if you're not sure how to do any of these things, definitely please refer your patients out to a Menopause Society certified practitioner or an ISHWISH fellow or somebody that can help you out and help manage these patients. And that is it. I'm going to end here. And so I hope this talk was helpful and to you, and I hope you learned something. So that is it. Thank you so much.
Thank you so much, Dr. Lid. That was extremely fascinating. I think you addressed a lot of things that many, just generally in the general community, as well as medical professionals, when it comes to the basics of menopause, especially some of the reservations that patients may have when it comes to hormone therapy, you really helped to provide us with some resources and some means of guidance for them. I have so many questions, actually. Just want to pick your brain if you would allow me maybe 5 or 6 minutes or so of your time.
Sure.
One question that I was curious about was for women who use hormonal contraceptives, have you noticed any connection between their symptoms or their length of perimenopause? Did you notice any type of connection, or is there any research regarding the connection between women who use hormonal contraceptives and their experience with when they do go through menopause?
Yeah. So are you talking about their continuing? So actually, the Menopause Society just came out with a clinical pearl in January 16th of this year, talking about contraception in perimenopause, menopause. We know that in perimenopause, women can still get pregnant because they're still ovulating. So for them to still be on hormones, oral contraceptives is still actually a possibility up until the age of 55 if they wanted to continue. Because what hormones do is not only is it birth control, not only is it suppressing ovulation, but it is providing hormones, although they are synthetic, because you have the ethinyl estradiol that are in most birth control, along with different types of progesterone. One of them is there's drospirenone, there's norethindrone, but those women that are able to remember, not a lot of women can continue to stay on birth control as they get older, because a lot of women will develop, if they're smoking, they can't stay on it after the age of 35. If they have high blood pressure, they can't stay on it after the age of 35. So it's really important to look at risk factors, but barring any problems with their medical history, they're able to actually stay on birth control pills if they want to up until the age of 55. Although I would say that the better thing to do would be to transition them over to menopausal hormonal therapy. You're actually getting more hormones with birth control than you are with menopausal hormonal therapy. With menopausal hormonal therapy, you're actually getting a lower dose of hormones. And a lot of times we'll end up giving transdermal, meaning like a patch or a spray or a mist or something like that, which tends to be a lot safer than oral. It carries less risk than oral. But if you're doing okay on, you won't have experienced those symptoms as much if you're on birth control, because you're not getting those fluctuations of estrogen. It's going to be a pretty stable dose that you're getting with birth control. And so, you may not even have many of those symptoms.
Thank you for explaining that. I also had another question about, and also thank you so much for clarifying the WHI study. When it comes to certain patients that some medical professionals may have that have reservations to using hormone replacement therapy, what type, from your personal experience, personal professional experience, what type of reservations do you notice certain patients having, and how do you help to explain things, especially if they do tend to have some misconceptions towards what has previously been studied and some of the debunking regarding those
Yeah. Are we referring to patients or to practitioners?
patients? And then just what kind of guidance would you give medical professionals who may find themselves in a similar situation, such as a PCP?
Absolutely. So medical practitioners, I would definitely ask them to look at the WHI study. And also, there's been so many reanalysis of that study that have been published. And so I think that it's really up to us to really continue to learn and understand what that study meant and who the patient population was and who they were studying and what it actually means now and how those results were debunked and what their conclusions are now. And I would also ask PCPs and really anyone that wants to learn more about estrogen to really go and read that book, Estrogen Matters. I would also even ask you to listen to my podcast. I have a podcast called the Muslim Sex Podcast, and I go over Menopause 101. I host free webinars. And I think that all of that information just being out there is really, really important to helping us understand what perimenopause is, what menopause is. For patients that may not understand really what they're going through, I would, suggest you sitting down with them. It's just that it's really hard, I think, with the current model. And that's why I do concierge. So patients that are in New York are more than welcome to see me because I spend about 60 to 90 minutes with each patient, their first appointment, just because I do a lot of teaching and I help patients understand really what is going on in their bodies. So I think for patients, I think it's going to be really important to do some more research, read books, lots of books out there on menopause that have come out from authors like Dr. Jessica Shepard. There is another author, Mary Claire Haver. I mean, there's so many people that have put out books on menopause. I think that those are fantastic resources. Estrogen Matters, that's another good book. I'm in the process of writing a book. So I think that there are definitely a lot of resources out there. You just have to find which one resonates with you and then read that and then become empowered.
Excellent. Thank you so much. I'm actually a longtime listener of your Muslim Sex podcast as well. I highly
Oh,
recommend it to listeners out there. Also check out the drsadaf.com. We'll be anxiously awaiting your book whenever you have it released if you would love to share more information about that. We would also the Iman education community would love to have you back. I know there's so much more that you can share with our community, especially regarding sexual health and mental health, like you touched on briefly in this session. Perhaps in the future, perhaps in April, actually, after Ramadan.
sure.
If you are available, we would love to have you back at least sometime in the near future and kind of have a part two session, but also give us some time for the listeners who are here and listening to the recording to share some questions. And then I'd be happy to share them with Dr. Sadaf, given her availability. But
Sure, absolutely. And I am always accepting suggestions for topics for my podcast. So if anyone has any topics that they want me to discuss, I'm happy to go over them. February is actually a month that I've dedicated on my podcast to sexual health. So this month, every Friday, I drop an episode. And so this whole month is on sexual health. I also am giving a lecture to OBGYNs next Wednesday through the OBGYN Project on Female Sexual Dysfunction. I'd be happy to give that lecture to IMANA as well. It's a very important topic and something that we just don't get much of at all. And I think that there is a huge taboo and stigma in our own communities regarding this topic that I think really doesn't serve our communities very well. And I think that a lot of people suffer in silence because of that stigma and taboo.
absolutely, absolutely. We graciously appreciate all of the resources that you would be willing to share with our community. I know many people are interested in learning about it and being able to have even a virtual platform within their comfort of being able to learn about it. Is a wonderful thing to have that option. But thank you so much, Dr. Sadaf. We're so grateful that you were able to make some time for us, and we hope to have you in the near future. As she mentioned, as Dr. Lodhi mentioned, if you have any particular topics of interest that you would love for Dr. Lodhi to come back and discuss, please let us know and reach out to us, and we will then share that information with her. But until then, we hope to see you all next month. Dr. Lodhi, thank you again on behalf of the Amana community. You have a good rest of your evening, and we hope to see you again soon.
Thank you so much. Thanks for your time.
Thank you. Assalamu alaikum wa rahmatullah.